Please start, ma'am. We are live.
Good evening and thank you all doctors and esteemed faculties for joining this virtual conference on Gynecological Cancer Management 2026. Welcome you all. Let me now invite our program convener, Dr. Arun Ramanan, clinical lead and senior consultant medical oncology, specialized in chemotherapy, targeted therapy, bone marrow transplants, immunotherapy, and CAR T therapy, Gleneagles Hospital, Chennai. We welcome you, sir. Now over to you for the introductory and your talk. Thank you.
Yeah, thank you. Thank you very much. Today we are here for discussing on gynecological cancer management. We all know that gynecological cancer plays a very important in women health. It's one of the important causes for the mortality and as well as morbidity for all the women. In India, the gynecological cancers are on top leading number of most 5 cancers. So we know that CA cervix and CA ovary are all increasing in incidence because of the lifestyle and as well as due to several other reasons like infections. So unless we properly manage these patients, the health burden is going to be on increasing it for its demand. So for the context setting, we need to know the updates happening in the gynecological cancer management for effectively treating these malignancies. Today we have eminent panel where all the speakers here are able to deliver their top-notch session today. So with that, we will be seeing we'll be hearing their talks, and we can refresh our knowledge here for all this management of gynecological cancer. As per the agenda, I may first start with the initial topic. Let me share my slides, then it can be followed. So without taking much time, I may share my slide here. Are my slides properly visible? Are my slides visible?
Yes, sir. Yes, sir.
Yeah, okay.
Visible.
So let me first start with the management of newly advanced ovarian cancer. We all know that ovarian cancer is one of the deadliest gynecological malignancy, where most of the patients present in advanced stage because of their vague symptom of presentation. Most of patients may present with vague symptoms like abdominal discomfort or pelvic pain or back pain, or sometimes abdominal distension, loss of appetite. Due to this non-representative symptom, most of the patient may land up to our OPD at a late stage. There are no effective screening markers. There are no effective screening tools available. There are no tools to diagnose these ovarian cancer at the early stage, even though the patients have the family history suggestive of some genetic etiology. Still, we lack an effective tool to diagnose these patients in their early stage. So, but even otherwise, outside this remark, early diagnosis is the key for success, whereas it is very difficult and challenging. Otherwise, if we don't diagnose the disease at the early stage, we may land up with a very big challenge, and these patients will have only poor prognosis because of the late stage. Comprehensive approach like surgery, chemotherapy, and other targeted therapy approach and advanced surgical care are required to improve the outcome. Globally, this also represents one of the 5 cancers, major cancers, which can by presentation. And in India also, the global incidents are very much closer. We are also reaching the global number of cases. highest incidence in high-income countries and rising incidence is seen in the developing nation. The 5-year survival rate still remains to be very dismal because of the suboptimal outcomes happening with the high advanced stage of the disease, particularly in poor countries and developing countries. If you see the pathogenesis here, I have the list. Most of the pathology belongs to high-grade serous carcinoma, up to 70% of the cases. And the risk factors for these epithelial cancers are BRCA1 and 2 mutations, specifically for serous epithelial carcinoma. Then Lynch syndrome, and family history of ovarian or breast cancer can also contribute to some extent because of the shared etiological risk factor, environmental risk factor. Nulliparity or in nulliparity contributes major risk for development of ovarian cancer. Older age group is also again a risk for developing ovarian cancer. Hormone replacement therapy definitely contributes increased risk. As we discussed earlier, the symptoms are not very specific. Mostly it will be vague symptoms. Abdominal distension, bloating, pelvic pain or abdominal pain, early satiety, loss of appetite, increased frequency of micturition and urgency of micturition can only be presenting symptoms. With this presenting symptom, mostly we have to have a high suspicion of developing ovarian cancer. So unless the family history or other etiological factors are there, it is very difficult to have high degree of suspicion about ovarian cancer. So that's why most of the time when patients land up to the general physician or family physician, they sometimes miss to diagnose this ovarian cancer at early stage. Advanced disease also may present with pleural effusion, ascites, and bowel obstruction. So we have to have this high degree of suspicion about ovarian cancer. Sometimes these laboratory investigations and tumor markers can help us to get more nearer to the ovarian cancer diagnosis. Like sometimes CA125 may be a sensitive tool. Up to 80 to 90% CA125 will be raised. Along with CA125, other markers like HE4 can also increase the sensitivity, but specificity again remains a big challenge. Roma score is very useful for calculating the risk of the ovarian cancer. When a high degree of suspicion and when you want to evaluate, imaging tools like CT abdomen and pelvis, MRI, and sometimes PET-CT can be useful. PET-CT is useful for diagnosing ovarian cancer when the disease is very much confined to the pelvis or to the abdomen. But PET-CT can rule out, or PET-CT can give you information about the extra-abdominal disease. Histopathological confirmation is very much mandatory, but it is very difficult one in CA ovary, because if patient presents with ovary confined disease, you should not try to poke it by percutaneous needling or transvaginal needling, because it will upstage the disease. There, with high degree of suspicion, you should go for the definitive diagnostic procedure called staging laparotomy. Staging laparotomy can be preceded with DLAP, but DLAP is only a screening tool, kind of like it can only with that DLAP you can only look into the abdomen, but definitely you cannot get a biopsy for a ovary confined disease. If it is a ovary confined disease, you should do staging laparotomy and convert it into the surgery. Before surgery, if you poke the ovary, then it will upstage the disease. But if the DLAP gives you clue that there can be disease outside the ovary, if it is the capsule is breached and if the disease has come out into the peritoneum, then you can take a tissue sample and subject it for histopathological diagnosis. But simple FNAC or ascites cell cytology may not exactly give you data about the nature of the disease and further genetic biomarkers. It can only confirm you the disease, but eventually for prognosis and as well as for as a predictive marker, you may need tissue, which is essential for further ancillary studies outside the histopathological test, like for doing molecular profiling. So this is a staging. Staging is done by TNM and as well as FIGO stage, but FIGO staging is the widely practiced staging system for ovarian cancer. If it is, most of the patients will present in stage 3 and stage 4 cancer, where the ovarian cancer have spread out of pelvis to involve peritoneum and the lymph nodes, that is into the abdominal cavity. Whereas stage 4 means extra abdominal sites are involved, like it can be pleural effusion, it can be parenchymal liver involvement. Even though it is inside the abdomen, it is if there is a parenchymal liver involvement, it is said to be stage 4. And splenic parenchyma and extra abdominal sites all contribute to stage 4. The histopathological types mostly associated with ovarian cancer are high-grade serous carcinoma. Up to 60 to 70%, it is the predominant histology. Then comes other histological varieties like epithelial cancers contribution with endometrial carcinoma, clear cell carcinoma, mucinous carcinoma, and sometimes low-grade varieties. Surgical management is primarily with primary cytoreduction. Maximal cytoreduction to achieve R0 or R1 is the main objective involved here. You can use the room. Patient selection is key for achieving R0 or R1 resection. If it is operable disease with good performance status and limited comorbidity condition, then you should always try for maximal cytoreduction, that is R0 or R1. The goal of the resection is surgical resection is to achieve maximal cytoreduction and leave minimal residual disease. That is called optimal cytoreduction. That minimal residual disease should be aimed at no macroscopic disease left there. That is called optimal cytoreduction. Initially, it was quantified like less than 1 centimeter disease to be left there inside the body. That less than 1 centimeter, or however you say, no visible macroscopic disease, all are reflecting into R0 or R1 resection. Only this R0 or R1 resection, that is the maximum cytoreduction or optimal cytoreduction, will only lead to improved survival and improved PFS and all the better outcomes. That all happens with R0 resection. Most of time when patient presents with advanced stage, R0 resection or R1 resection will not be a possible one unless if the disease is confined to very limited stage like stage 1 or 2. In those situations like advanced disease, we may need neoadjuvant therapy to downsize the tumor and make the disease operable. This is not only going to help for operability, it also helps for reducing the surgical morbidity. The neoadjuvant chemotherapy actually it is not improving the overall survival, but it eventually improves the overall outcome of the disease in the form of reducing the morbidity, increasing the operability, lesser resection rates. Indications are usually whenever there is an inoperable disease at present, when the patient is having comorbid conditions or extensive disease burden or poor performance status, which is going to lead to high morbidity in any surgical candidate. In those situations, we can try with 3 or 4 cycles of standard of care chemotherapy for the first line neoadjuvant option with the carboplatin and paclitaxel doublet. Carboplatin is given at a dose of area under curve 5 and paclitaxel at a dose of 175 milligram per meter square. Followed by followed after 3 or 4 cycles after that if the patient has shown some response, which can even be understood with some imaging modality like CT or MRI abdomen, then these patients can be subjected for interval debulking surgery. If upfront the surgery is done, that is called optimum site reduction. If it is done after neoadjuvant chemotherapy, we call otherwise it is the interval debulking surgery. Sometimes when there is some amount of peritoneal disease is left, we can try hyper chemotherapy along with this interval debulking surgery in a selective subset of patients. As I mentioned, carboplatin paclitaxel is the doublet considered to be the standard of care. Otherwise, it can be alternative regimens kind of dose-dense therapies like dose-dense paclitaxel, cisplatin instead of carboplatin for some patients, and then docetaxel as a replacement for carboplatin can all be a alternative schedules, but current standard of care is pacli and docetaxel. Dose-dense paclitaxel or dose-dense nab-paclitaxel are considered to be alternative, which is slightly increasing the resection rates. Intraperitoneal chemotherapy may be considered for high stage 3C disease patient where a good response and optimal debulk is achieved. Some high-risk patient may also be considered for bevacizumab in the neoadjuvant fashion. In case if they underwent surgery after bevacizumab, then they also have to carefully follow with the bevacizumab in the adjuvant fashion. Hyperthermic intraperitoneal chemotherapy is one of the new additions into this surgical technique. It can be administered along with cytoreductive surgery. Randomized trials have demonstrated very good PFS rates with the HIPEC, particularly where patients are having residual disease after neoadjuvant therapy. But it has to be selectively done in a specialized center where they have a high volume experience with HIPEC therapy. Selected patients who undergoing this interval debulking can be benefited with HIPEC, but they should have a good performance status and limited comorbid condition and limited peritoneal disease after the neoadjuvant therapy. The molecular testing, which I initially mentioned during, which is quite a useful tool before starting a therapy when we have a biopsy, is for this BRCA1 and 2 mutation analysis. It can be both germline and somatic testing. Additionally, HRD testing can also be done. This is going to give a lot of information about the prognosis and as well as the prediction of response to the subsequent therapy. Additional biomarkers like MMR testing and PD-L1 expression can be useful for advanced disease. Targeted therapy like VEGF inhibitor, that is a bevacizumab, has been tried and found useful in terms of improving PFS for these advanced CA ovary patients. This has been already proved with GOG 218 and ICON 7 trial. They have found modest improvement in the PFS. There are trials which have shown that PARP inhibitor in adjuvant therapy has shown a very good improvement in survival. Solo 1 is a study which proved olaparib it's very useful in improving the PFS from 13.8 to 56 months for all the germline and somatic BRCA mutated advanced ovarian cancers. PRIME is the other trial where it has shown niraparib is useful in improving the PFS from 11.1 to 37.2 months for all the HRD positive advanced ovarian cancer. Keynote 100 study have demonstrated pembrolizumab had shown some modest response in high PD-L1 positive tumors. It can even be combined with PARP inhibitor and other antigenetic therapy, where these ongoing trials has to address on the benefit out of these combinations. Mirasol trial has shown that mirvetuximab and that's the antibody drug conjugate against FR alpha positive platinum resistant ovarian cancer, where this mirvetuximab has shown some improved PFS and response rates versus chemotherapy through this MIRASOL trial. NOVA trial is the other one where we found niraparib has shown a remarkable PFS benefit in recurrent ovarian cancer, who has shown some uh, HRD positivity. This is the Atheno mono trial, where rucaparib was found to be beneficial in terms of PFS for all the BRCA mutated and HRD positive tumors, positive advanced ovarian tumors. So now we are able to see a good survival pattern for all these ovarian cancers because of the advancement happening in the field of surgery and chemotherapy in the way of neoadjuvant therapy and adjuvant maintenance therapies. So long-term toxicities has to be properly addressed and managed for these patients in the form of peripheral neuropathy, which can happen out of platinum and taxane therapy. Fatigue usually happens with all the chemotherapy. It can be a multifactorial, so it has to be carefully addressed and treated. For nowadays, we are seeing a lot of young patients with ovarian cancer. So sexual dysfunction is there as a potential morbidity for all the post-surgical and chemotherapy treated patients. Psychosocial support, fertility preservation, survivorship, and genetic counseling are very much required for all these patients. So I think I have done justice to the session given to me. Thank you very much. Hope if you have no doubts, and if you have any doubts, we can. I'll be privileged to answer those doubts, or otherwise we can take those doubts in at the last.
Thank you so much, sir, for the wonderful talk. So, do we have any questions? I guess no. So, our next speaker is Dr. Priyadarshini, Consultant Medical Oncologist, MGM Cancer Institute, Chennai. Welcome you, ma'am. Over to you for the talk.
Hello, good evening all. Hope I'll just share my. I hope I'm audible.
Yeah, you are audible, Priya.
Yes, sir. I'll just start with I'll just share my screen. Can you all see my screen
Not yet, ma'am.
now?
No, ma'am.
No,
Share from
just
our
give me a
side.
minute. Yes, sure. Very good.
Okay.
Yeah, I think now you can see the slides. Any-
Yes, ma'am. It's visible.
Okay. So thank you, sir, for giving me the opportunity to present this topic. And today my topic is the relapsed ovarian cancer management. So coming to the so we all know that ovarian cancer accounts for about 90% of all ovarian malignancies. And most of the patients, as explained by sir, will always present with advanced stage of stage 3 and 4. This is due to there is very less effective screening as well as non-specific early symptoms. Because patient normally will have like abdomen pain or increased urination. So they are not very concerned about all these things, and they end up in late stage in our clinic. And the primary standard of care, as discussed, involves the cytoreductive surgery followed by platinum as well as taxane chemotherapy. The main challenge is however we treat the patient. Most of the patients, 70% of the patient will relapse within 3 years. And to the reason for this is still there are many risk factors which are the reasons for this recurrence. However, when the patient is recurring, we always tell it is incurable, and our treatment goal shifts from survival to prolonging the survival to have a good quality of life and to reduce the patient's symptoms. So before going to the treatment, we should know what the relapse ovarian cancer is. There are many definitions which come along with this, so that these help in treatment, helping us with the treatment. So relapse is defined as an objective evidence of disease progression, which happens after complete or partial response of the initial treatment. So how do we find these? There are many diagnostic criteria. One is a rhesus criteria, which is diagnosed radiologically, where there is appearance of new lesion and there is 20% increase in the diameter of the target lesion. There is unifocal progression of non-target lesion, as well as patients who are eligible for the clinical trials. We do check for that. And second thing is symptoms. Patient is having new onset of cancer-related symptoms like ascites, obstruction, as well as pain. And there is a palpable mass on clinical examination, and the patient is having a deterioration in the performance status. Next comes the biochemical changes, where the patient is having a raise in CA-125, and this is like considered as the doubling time is what is considered, as well as not a single criteria of increase in CA-125 is noted. We have to check the CA-125 as a consequent within few weeks, which we will be discussing later on. Coming to the classification of recurrence, the reason for this classification is one, it is useful for prognostication as well as for the treatment strategy. There are main definitions which we have to remember. One is platinum refractory. These patients are the patients who progress on treatment or progress within 4 weeks from the last dose of chemotherapy. These patients do really bad. They have a very bad prognosis, and we have to enroll them in clinical trials, and also they are not really candidates for platinum therapy. The patients are patients who are platinum resistant who relapse within 6 months of the treatment. The 6 months cutoff is from the last platinum dose. These patients also respond poor to platinum. We can choose chemotherapy which are non-platinum based with or without bevacizumab. The third patients are partially platinum sensitive patients who have a 6 to 12 months of platinum free interval. For these patients, they do benefit with platinum, and also use of platinum as well as non-platinum also we can consider. But we normally in our clinic go with platinum doublet chemotherapy. And the platinum sensitive patients are patients who recur after 12 months of treatment. For them, platinum can be rechallenged. And also patients who are always platinum sensitive are always considered to be effective to take a PARP inhibitor as maintenance. So, as I previously discussed, the risk factor for recurrence can be predicted even before the patient really goes on a recurrence. One is the surgery, which is the main standard of treatment. Initially, these patients should have which should not have any residual disease. So, patients with the residual disease of more than one after primary debulking have a higher uh, recur- recurrence rate. And patients who are diagnosed as early stage, that is FIGO stage 3 and 4, even are at a higher uh, relapse probability. Third, patients who have a high grade serous are the most common subtype who always recurs. And also, the molecular determination is very important. Patients who are BRCA as well as HRD status um, should also be done, because the initial platinum sensitivity also influenced by the maintenance therapy. And also CCNE1 amplification is associated with primary platinum resistant and poor outcome. So at the initial diagnosis, it is always recommended that patient undergoes a molecular determination so that the prognosis as well as the risk of recurrence is also kept in mind at the time of the initial treatment. How these patients clinically present? They present with um, symptoms of ascites, early satiety, bowel changes, bloating, and the most troublesome changes, symptoms that the patient comes with is fatigue, weight loss, urinary frequency or urgency due to bladder compression. And also the most acute and emergency conditions which we have to deal immediately are the bowel obstruction, pleural effusion because patient will present with shortness of breath, cough, and chest pain, deep vein thrombosis or pulmonary thrombosis, as well as hydrourethronephrosis. So these patients who are already a known case of celiac ovary who had completed the treatment, now we are suspecting recurrence. How do we clinically go about? First is the clinical examination. We have to examine, see the ECOG performance status and the burden of disease. So, which is primary reason for the recurrence and what is going to relieve the patient from the symptoms. Second is our laboratory assessment where CA-125 is done, renal as well as hepatic parameters, a complete blood count. Also, in patients who are having a non-specific CA-125, HE4 is also considered. And the imaging wise, CECT, chest, abdomen, and pelvis with contrast is always considered first line. MRI or a PET-CT is also good enough if we are planning for a surgery. And biomarkers to be re-evaluated. So when do we consider a biopsy in these patients who are recurring? It is considered when the patient is having a relapse of atypical interval as well as more than 2 years interval is also a good candidate for biopsy. And also the biomarkers which we have done previously will also help in the diagnostic approach in the way that we know that this patient will recur and we'll have an idea of what is to be done. And coming to the imaging modalities, which I already discussed, CECT, abdomen, chest, and pelvis. MRI, which is superior, shows a soft tissue contrast for the pelvic recurrence. And MRI is normally indicated when the patient is having a retrosigmoid involvement assessment to be done, and whether there is a equivocal liver lesion as well as brain MRI should be done. FDG PET in our clinical practice, we always go ahead and do a FDG PET, which is actually highly sensitive for nodal as well as distal widths. And also, when the patient is, we are planning for a cytoreduction, we go for FDG PET, but it is still not considered as a standard of care. So, coming to the tumor markers, many patients in our routine will come with only CA-125 and USG abdomen. CA-125 is very important. However, even if there is a significant increase in CA-125, we should be very careful in how we go about and treating the patient. So, CA-125 elevation proceeds to critical as well as relapse in around 20% of the patients. However, doing CA-125 regularly or the still increase in CA-125 is did not show any overall survival compared to waiting of the symptom. And current do not initiate chemotherapy just based on the CA-125. So when CA-125 is increasing, we have to keep a lot of things in mind. So CA-125 should be documented to the initial treatment so that we will know which is the normal level of CA-125. So increase in normal level of CA-125 and the upper limit on two different occasions. The two occasions should be like at least more than 1 week apart. And in some patients, the CA-125 will never normalize. So in that case, we should consider nadir amount increase from the nadir amount of more than times in two different occasions. So what we can predict is we can be careful that increase in CA-150 patient will definitely relapse over time, this can be seen radiologically. And the treatment goal in relapse mainly focuses on the chronic disease management. Curative intent is actually reducing the patient relapses. And also we have to see in treatment, we have to keep the quality of life which we are going to give them when we are going for the treatment, the toxicity, as well as how much extent and the survival we are going to provide for them. And the personalizing factor which we are doing is one, the BRCA mutation, the HRD status, and the FR alpha expression level. Doing the FR alpha expression level is for starting of the motonil, the margetuximab, but it is done as a IHC, and mere expression of FR alpha doesn't prompt us to start with the treatment. We have to make sure that tumor cells are at least having more than 75 percentage of expression, and some patients who are having more than 50% expression, we can have bevacizumab along with the target drug. And as we discussed earlier, platinum is very important for determining the treatment, as well as targeted bevacizumab exposure is also very important. Patient's profile, which is the performance status, comorbidities, and residual toxicity should be kept in mind. And the treatment logistics as well as what patient wants also should also be kept in mind. Coming to the platinum sensitive variants, as we discussed, these patients can be partial platinum as well as who recur after and come sensitive patient who recur more than 12 months. So first option in our mind is always go ahead and give platinum. So you use carboplatin paclitaxel, with patients will have a high response to the doublet platinum. But we have to keep in mind the toxicities when we are treating, because previously also we have treated the patients with platinum. Second thing is second option is gemcitabine with platinum, and third is carboplatin with liposomal doxorubicin. So each patient, along with platinum, whatever you're going to combine with, we have to keep in mind toxicity profile and should be explained to the patient what toxicity can be expected when we are starting the platinum doublet treatment. Next is the maintenance strategy, where the PARP inhibitors are used, as well as bevacizumab maintenance also can be considered. And what do we expect out of treatment? There is a ORR of 40 to 60% with platinum doublet, and the median progression-free survival also in OS can exceed up to 30 months in a modern series. However, it depends on the patient's performance status and other comorbidities and other criteria depending on the overall survival. So, which you already discussed. Platinum with paclitaxel have data, which is from the ICON 4 and OERA 2.2, which show overall benefit. And second one is platinum with gemcitabine with NO 2.5. And addition of bevacizumab with carboplatin and gemcitabine was discussed in Oceans, which also showed progression-free survival. We should always consider the hematological toxicity when we are adding gemcitabine with carboplatin, keeping in mind the neutropenia and thrombocytopenia. And patients with carboplatin with liposomal doxorubicin, we have patients still had progression-free survival, but overall survival was non-inferior. Here, this patient, we have to explain to them about the hand-foot syndrome and also what to be considered when the patient is having hand-foot syndrome. The PARP inhibitors in platinum-sensitive relapse, the data go to which showed progression-free benefit in adding olaparib, and NOVA which showed progression-free survival benefit of 15.5 months with niraparib. So these patients when starting on olaparib, we have to look for like regular CBC count in view of low hemoglobin as well as low counts, and clinical examination once in a month is always necessary. Coming to bevacizumab, And clinically, what I have found is patient like this benefit better than maximum bevacizumab. When you're doing platinum, um, discussed in Ocean's trial, showed in a progression survival, not statistically significant. These patients who we had bevacizumab should be told about the chances of perforation, which is very high from our practice. We do serial as well as post BP monitoring for looking for the hypertension every time when they visit our clinic. So I'm just putting on the platinum sensitive recurrence. So the first thing is biomarker status, whether the patient is BRCA mutated, HR positive, as well as both are negative. These patients, platinum sensitive, are all sensitive to platinum. So go ahead and give doublet. And if they are BRCA mutated as well as SRD positive, you can also add PARP inhibitors. If BRCA and HRD patients, you still have the option of using bevacizumab. Patients who are negative, go ahead and start it with bevacizumab. And personally, I feel bevacizumab is much beneficial in patients with ascites. Coming to the platinum resistant recurrence, again the same thing. We have to stay this where these patients are not very good with platinum, so we look for other chemotherapy agents like paclitaxel, topotecan, and cisplatin. These patients, the bevacizumab, if it is not contraindicated, and it was proven by Aurelia trial, which showed the improvement in PFS as well as ORR. And these patients who are platinum resistant have prioritized the toxicity as well as the quality of life when you're going for the treatment. And these patients also should have done a FR alpha testing. And patients who are high, more than 75%, we can go ahead and give mirvetuximab. Patients who are MSI high can be considered for pembrolizumab as well as dostarlimab. Patients who are germline BRCA positive can be given PARP inhibitors. So, as we discussed, the reference of chemotherapy which we are using is weekly paclitaxel, pegylated liposomal doxorubicin, topotecan, and gemcitabine. All have shown ORR, moderate PFS, and not much OS benefit. And bevacizumab in platinum-resistant disease, as we discussed, Aurelia had combined bevacizumab with other chemotherapy, which showed PFS benefit. However, ORR was not achieved. And coming to the immunotherapy, like patients who are the MMR as well as MSA high, we can give pembrolizumab as well as dostarlimab. And other chemotherapy, other immunotherapy drugs like avelumab as well as nivolumab did not induce any PFS or as well as benefit. So by combining the strategy, like what we're going to add on matters, and the mixed cells are also being considered, but in practice, we haven't combined most, like as far as what I have seen. And coming to the cervical marriage, we have very good data of the stuff which showed patients even after can go ahead for a secondary site infection. But the previous criteria should be kept sports to for a secondary cytoreduction. PCOG performance 0, a size of less than 50 ml, and the patient who had complete resection at the primary uh, surgery. Normal, these patients are good candidates for secondary cytoreduction. And how to monitor the treatment terms, we see the clinicals have to see the assessment, look to the toxicity profile, the quality of life, treat them conservatively. And imaging is considered only at least 2 to 3 months after the initiation. And total saving, we after 3 cycles, we ask the patient to go for a EVG, and the progression is like
Ma'am, your voice is breaking a lot.
patients who are Can you hear me now?
Yes, ma'am.
Yeah, anyway, I'm at the end of the presentation. And that was the last slide of references and the key guidelines. Thank you. Hello.
Hello.
Yeah. Any questions?
Any questions from anyone? Or should we move to the next session? Okay. So thank you so much, ma'am,
Thank you. Thank
for
you all for this
the
wonderful opportunity. Thank you, sir.
thank you. Thank you, ma'am, for the insightful talk. Our next speaker is Dr. Vedant Roy, Consultant Medical Oncologist, T. Raja Cancer Care, Apollo Hospital, Chennai. We welcome you, sir. Over to you for the next session.
Yeah, thank you for inviting me to this platform. So my topic is HER2 Climb 05. So basically the rationale for this study was the HER2 Climb, which was capecitabine with trastuzumab and tucatinib, which showed a significant and impressive CNS PFS with an impressive hazard ratio. But that was on more than the second line, roughly the third line patients. So based on that rationale, the tucatinib maintenance was applied to the first line for HER2 positive metastatic breast cancer patients. So that's where HER2 Climb 05 this year with a significant PFS in the first line is a very significant study. So the introduction, the current standard of care for first-line HER2 positive metastatic breast cancer is induction chemotherapy with taxane with dual anti-HER2 antibodies as trastuzumab and pertuzumab, followed by maintenance therapy with trastuzumab and pertuzumab. However, most patients eventually experience disease progression on the standard of care regimen, and most of them will not even reach the second-line treatment. The HER2 Climb trial demonstrated that adding tucatinib, a highly selective HER2 tyrosine kinase inhibitor, to the capecitabine and trastuzumab in the HER2 Climb study, that a significant PFS, OS, and a CNS PFS was achieved in the third line. Optimizing the first-line maintenance therapy by targeting the HER2, both extracellular and the intracellular blockade, may improve the patient outcomes because the HER2s and the trastuzumab are the extracellular targets and tucatinib is the intracellular targets. So blocking both can give up improved outcome. That was the biologic rationale in the study. So the phase 3 HER2 Climb 05 was initiated to investigate this efficacy and the safety of adding tucatinib to the HP, that is Herceptin and the pertuzumab, the first-line maintenance therapy in patients with metastatic breast cancer, HER2 positive, who had completed induction therapy with the triplet without progression. So the study trial design, definitely it's a centrally confirmed HER2 positive disease with no evidence of progression of at least 4 to 8 cycles, or patients who have not received the full 4 to 8 cycles in view of intolerance were also included in the study. ECOG performance status of 0 or 1, both with brain metastasis and without brain metastasis were part of this study and was confirmed by contrast-enhanced MRI screening. So the first, and so it was a randomization of 1:1. where you can see that the tucatinib 300 BD with HP and along with endocrine therapy in patients who were both HER2 positive as well as endocrine positive, the ERPR positive. So it was 1:1 randomization, and the endpoints were the primary endpoint was investigator-associated PFS, and the secondary endpoint was PFS by the BICR to remove the intentional bias from the investigator, and the OS and the CNS PFS, apart from the safety and the quality of life. So this is the consort diagram with the 1:1 patients randomization showing in the chart as shown. So roughly 176 patients, on the left lower side, you can see that 176 patients remained evaluable for the results. So this is the patient characteristics. The median age was 54 years for both the arms, that is tucatinib with HP and the placebo with HP arm, and the predominantly white and Asian, followed by the blacks. So hormone receptors positivity was also part of this study, significant. Around 51% patients were hormone receptor positive. Brain metastasis were in total around 81 patients out of the net 678 patients. And also the de novo and recurrent, both the patients were taken in. So the median cycles were 6 to 8 cycles, which were exposed in the triplet and has not progressed after 6 to 8 cycles exposure. So this is the primary endpoint. You can see the curve, that is the investigator-associated assessed PFS. As you can see, it's an 8.6 months benefit with a hazard ratio of 0.64. There's around 36% reduction in the disease recurrence or progression, rather, progression. So it's a significant improvement as a first-line maintenance. So here in the forest plot, you can see the different subgroup analysis, the hormone receptive patients with a 0.55 HR has shown quite a good PFS, and hormone negative and positive, the negative were 0.55 and the positive were 0.72. Definitely they need the endocrine therapy along with it. And the brain metastatic patients where was present with 0.64 and 0.64 both almost identical. But actually the CNS PFS of this study is yet to mature. This study became significant due to its PFS data, but the CNS PFS data is yet to mature. That's why the brain metastasis baseline, you can see around 81 patients, both the hazard ratios are comparable of 0.64, 0.64. Even patients who had visceral involvement had shown a significant PFS benefit with 0.64 of hazard ratio against the patients who did not have any visceral mets. So by the hormone receptor status, as I said, on the left side, the hormone receptor negatives were pure HER2 positive disease, showed a 0.55 hazard ratio of gain of 12 months as compared to the placebo. And the hormone receptor positive on your right side, you can see a gain of around 7 months with a hazard ratio of 0.72. Understandably, they had endocrine therapy along with this quadruplet. So this is the centrally assessed PFS, which they found that it is almost identical to its investigator assessed PFS. It's 0.64 and the BICR also showed 0.65, but the gain of 12 months roughly. The OS data is actually yet to mature, but still it shows quite the white curves in between with a 0.5 through HR, but it's yet to mature. So it shows a promising OS benefit as well. The data is yet to come. As I said, the CNS PFS data of its prior study, the predecessor study, that is the HER2 climb, there was a benefit of CNS PFS of around 0.68 or 0.34. I just don't remember the value. But this study too, if you look at the exploratory arm that is on your right side, only 81 patients with this triplet, around hazard ratio of 0.71 and a gain of 4 months, but it is yet to mature. So this data is not yet the final, it's the interim data. But on the left side, as you see, the intention to treat population as such, the curves didn't widen. So maybe in the coming year, Dr. Hamilton will come with the better curves. Safety profile, as we can see this in the triplet, the grade 3 is around roughly 42% of the patients had the grade 3 type of side effects, which is predominantly diarrhea, followed by hepatotoxicity, myelosuppression chronologically. And all the side effects were reversible following drug holding, drug holiday, or dose reduction. So this is the histograms, which shows that the diarrhea was predominant in both the arms, where the grade 3 was much higher in the triplet, around 6% of the patients who got the triplet, as compared to the doublet with placebo were 4%, followed by nausea and the hepatotoxicity, and arthralgia, fatigue, myelosuppression. So that's what. So the conclusion from this study is addition of tucatinib to first-line maintenance with the doublet demonstrates a statistically significant and meaningful PFS benefit in patients with metastatic HER2-positive breast cancers. So why to wait for the third line when we can achieve an effective 2-year benefit in the first line? So that was all Dr. Erica Hamilton appealed. So 36% reduction in the risk of disease progression or the death, with a PFS benefit of around 8 months, 8.6 months improvement. Benefit was observed across all the patient subgroup, as we saw in the forest plot. The OS data is still preliminary. It's interim data, as we discussed. The data is yet to mature. So the triplet combinations was a manageable safety profile, as we said, that drug holding, drug holiday, and dose reduction can definitely reverse the side effects of diarrhea, nausea, hepatotoxicity. Except one patient in the study, as they are presented, had DILI grade 5. But again, that patient was off the trial after DILI. So HER2CLIMB-05 has demonstrated the addition of tucatinib to the doublet represents an enhanced first-line maintenance therapy option for patients with HER2 positive, providing an opportunity to prolong time to disease progression and the time of the chemotherapy. So the major takeaway is that why to wait for the third line when we can give maintenance in the second line and achieve a significant PFS and save the patient, because majority of such patients don't even reach the second line. So so Dr. Erica Hamilton's study in the ASCO appealed this particular point. That's all. Thank you.
Thank you so much, sir, for the wonderful talk. I now welcome our next speaker, Dr. Sriram, Consultant Medical Oncology, Orimai Hospital, Tirunelveli. We welcome you, sir. Over to you for your next talk.
So good evening all. Am I audible?
Yes, sir, you are.
Can you share my slides, madam?
Sure, sure.
Yeah, so good evening. Thank you, Arun Ramanan sir and team for the opportunity. Today, I'll be talking about advances in management of breast cancer as a whole. The previous speaker, Dr. Vedanta, actually beautifully spoke about tucatinib alone. So I'll be covering about breast cancer as a whole in detail. So next slide. So if you look at the disease burden at present, breast cancer, it accounts for around 2.3 million new cases, and 1 in every 28 women are at risk of breast cancer. Indian women as such, there is 8 to 10 year younger predilection compared to the Western population. And despite all the screening protocols that we follow, still 50% of the Indian patients have the previous slide. So we have 50% of the Indian patients presenting in the locally advanced or in the metastatic setting. However, screening coverage also leads to the earlier predilection, picking up the disease earlier. And region-wise, there is a higher predilection in the urban areas compared to the rural area. And biologically, TNBC has become slightly more commoner in India. As such, there is still a public health gap in India, which needs improvement. Next slide. So breast cancer is a heterogeneous malignancy. As such, as we all know, so we have the luminal A and luminal B subtype, which is the most common subtype. it's a hormone driven cancer. So we have multiple endocrine therapies and the CDK4/6 inhibitors to back us up, and it has a favorable prognosis. Coming to the HER2 positive disease, it has high proliferation. However, we still have anti-HER2 therapy in the form of trastuzumab, pertuzumab, TDM1 and TDXD, which helps us to cure the disease better. And with respect to the TNBC, there is no hormone receptor or HER2 expression. So there is as such no effective treatment option apart from the immunotherapy and the newer ADCs, which I'll be discussing later. And then comes the newer entity, which is the HER2 low, which we'll be discussing about the concept of HER2 low later. This is coming up in a big way, where trastuzumab deruxtecan has been approved in the management of CA breast, which is HER2 low. Next slide. So coming to the risk factors, we all know this: increasing age, female sex, and patients with positive family history. Then genetic factors like the BRCA and the Laframini syndrome. Then patients with dense breast and the reproductive history, that is nulliparous women and patients who have not breastfed their children adequately. They have more predilection to CA breast. Also, estrogen itself is a contributing factor. And apart from that, the hormonal imbalance, the lifestyle factors, and drinking and smoking, along with radiation exposure, contribute to CA breast. Next slide. So where have we actually come? We have actually come a long way with respect to treating CA breast. Earlier in the 1990s up till the 2010s, we had surgery, chemotherapy, and radiation. Probably the cancer care in CA breast was pretty easy. So this itself had improved local control, but there was still high recurrence. Slowly, in the end of the 2000s and the beginning of the 2010s, we had the targeted therapies coming up. Now, slowly, we are heading to dual anti-HER2 therapy. We are heading to CDK4 inhibitors, and we are also heading to the immunotherapy and the antibody drug conjugates, which are coming up in a big way. Next slide. So what are the modern screening techniques? As we all know, earlier we had only mammography. Now we have better options like digital mammography, which has a better resolution, and it is available in many centers. So even the standard population can be screened effectively, and there is proven mortality reduction with digital mammography. The newer advances are digital breast tomosynthesis. This actually is a newer technique wherein the screener actually rotates around the axis of the breast, and multiple additional views can be obtained, and there is better visualization. So especially in the axillary tail, in the inferior quadrants also, we have better imaging to pick up the disease early. And breast ultrasound is nowadays used as an adjunct to mammography. So cystic and solid lesions can be made out better. Also, breast MRI has come up, which has higher sensitivity, and this is of good help in the high-risk women, that is BRCA positive patients and patients who have positive family history. We have to start screening at an earlier age. So this is of use when it comes to screening young females, especially in pregnancy. Also, breast MRI can be used. It has a sensitivity of around 90%. And recently, contrast-enhanced mammography has also come up, which is but the availability is limited. Next slide. So coming to the newer options, there is molecular breast imaging, which is the functional imaging in CA breast, which has a higher sensitivity to mammography alone. And as I discussed earlier, contrast-enhanced mammography, elastography, and automated breast ultrasounds have also come up. Liquid biopsy is also coming up, which I'll be discussing later in detail. Next slide. Now coming to the advances in surgery. Earlier, it was only MRM, but slowly the concept of organ preservation has come in. Earlier, it was breast conserving surgery and addition of RT being equivalent to mastectomy, which was supported by the NSIBP 06 trial. And then coming to the axilla, earlier it was axillary lymph node dissection, but slowly sentinel lymph node biopsy has now taken over, and that the evidence is ECOSOG Z11, which showed no survival loss by dissecting the axilla alone if sentinel lymph node is negative. And oncoplastic surgery leading to better cosmetic outcomes. That is, we have even after MRM we can do breast reconstruction, and also the de-escalation of RT to the axilla, which is supported by the Amaros trial, which showed that sentinel lymph node biopsy with RT is equivalent to axillary lymph node dissection, which offers lesser morbidity to the patient. Next slide. So coming to the topic proper, what are the endocrine therapy advancements? So hormone positive disease is highly sensitive to estrogen signaling. So now we have the CDK4/6 inhibitors, which is like the palbociclib, ribociclib, and the abemaciclib. In the adjuvant setting, we have approval for ribociclib and abemaciclib, while in the metastatic setting, we have palbociclib, ribociclib, and the abemaciclib. And SCRMs are already approved, which is fulvestrant, but oral SCRDs like the elastresen is also come up in the ESR1 mutated patients, which is one of the important resistant mutation to hormone positive breast cancer. And in more than 50% patient, as I discussed, there is a presentation is in the locally advanced or in the metastatic setting. So there is improved survival. The landmark trial was, as of today, among the 3 CDK4/6 inhibitors, ribociclib has already a proven OS benefit, while abemaciclib is showing a trend towards OS. So the Mona Lisa study, we have to remember 3 trials, which I'll be discussing in the next slide. It has improved local control. That is, first is the Mona Lisa 2, which included postmenopausal women in the first line in the metastatic setting, and the comparison arm was letrozole alone, which showed significant OS benefit towards ribociclib with letrozole compared to letrozole alone. That is, median OS was around 63 months. And in the Mona Lisa 3 study, this study included postmenopausal women, both in the first line as well as in the second line in metastatic breast cancer. But the comparison arm was fulvestrant. So there was a significant OS benefit. And in the Mona Lisa 7, perimenopausal women were also included in the first line metastatic setting. And the comparison arm was tamoxifen and ovarian suppression. So that also showed a marked OS benefit in younger women. So the key takeaways were the consistently it showed OS benefit in both the first line and the second line. Both premenopausal and the postmenopausal women showed better outcomes, especially the first trial to show OS benefit in the perimenopausal age group or in the premenopausal age group was the Mona Lisa 7. After this, it became the standard first line in the metastatic hormone positive setting. And also it may improves significant OS control in visceral diseases with liver and lung mets. Also, it maintains quality of life, and we can also delay the chemotherapy. That is, if the patient is having upfront meds, if the median OS being 63 months, there is a high chance that in the absence of visceral crisis, we can actually delay the chemotherapy. Next slide. So coming to the HER2 positive subtype, earlier it was only trastuzumab. Although trastuzumab offered a significant OS benefit, HER2 positive breast cancer being a very highly proliferative malignancy, they found that onset of resistance was very early. So dual anti-HER2 blockade with the pertuzumab also, it offered a deeper response. And nowadays, after pertuzumab, also now we have multiple ADCs, that is TDM1 and the TDXD, which has come up in a big way. Tucatinib, again, another anti-HER2 oral blocker. My previous speaker, Dr. Vedanta, has already detailed it in detail. So coming to the Cleopatra trial, which is based on which the trastuzumab and pertuzumab, that is a dual blockade, showed an improved OS. And also the Destiny Breast 03, that is standard second line therapy post progression on trastuzumab and pertuzumab was actually TDM1. So TDXD, that is trastuzumab deruxtecan, was also compared to TDM1 in the trastuzumab in the Destiny Breast 03. It also showed a significant OS benefit. Next slide. So as I detailed earlier, so the Cleopatra study, the population included was the HER2 positive metastatic breast cancer. This was in the first line. The regimens used was trastuzumab, pertuzumab, and docetaxel in comparison with trastuzumab and docetaxel alone. So the major takeaways were major OS improvement. The median OS was around 56 months. There was rapid tumor shrinkage and durable disease control. And it was irrespective of age, hormone status, or the site of the visceral disease. And there was a marked shift towards HER2 positive metastatic breast cancer becoming a chronic disease. and there was more time could be prolonged towards when the patient develops resistance. Next slide. And I already discussed the Destiny Breast 03. The key takeaways was there was PFS benefit when compared to TDM1. The response rate was around 80%, almost 80% patients achieved tumor shrinkage. And especially brain mets, TDXD had a better intracranial penetration to TDM1. And also in heavily pretreated patients, TDXD still showed survival benefit. And also there was a biggest margin of benefit was in the HER2 positive metastatic setting. And TDM1 was in the, so this trial led to replacing TDXD in the second line. So TDXD has become the standard second line therapy, replacing TDM1. Next slide. Now coming to HER2 low. So this is a newer concept. In the previous 2-3 years, it has become popular. So what is this HER2 low? So the definition is IHC 1 plus on a HER2 positive tumor, which is either showing a HER2 negative tumor, which is either showing 1 plus or 2 plus on IHC and FISH negative. So why is this important? Now 50 to 60% of HER2 negative tumors could land up to be IHC 1 or 2. Now, what is the advantage of identifying a HER2 low tumor? So TDXT has been approved after multiple lines in HER2 low setting, which has shown a definite OS and a PFS benefit. The landmark trial is Destiny Breast 04. Next slide. Now I've covered the hormone positive and the HER2 positive cancers. Now coming to the TNBC. TNBC is actually a subset which does not have any sensitivity to the estrogen or progesterone receptor blockade or the HER2 receptor blockade. So we actually didn't have anything till date apart from chemotherapy to substantiate survival in TNBC. The first drug to show any significant benefit was this pembrolizumab. It was actually approved initially in the metastatic setting, but end of 2024 or early 2025, as soon as the keynote 522 data came, there was an improvement in PAT-CR and there was an improvement in EFS when it was added to chemotherapy. Now the catch point is in early breast cancer, in triple negative breast cancer, it can be used irrespective of PD-L1. However, in the metastatic setting, we have to look at PD-L1. Only patients who had more than 10 CPS benefited from addition of pembrolizumab. So next slide. Now the keynote 522, which is the landmark study in the non-metastatic setting. In this study, pembrolizumab was added to standard chemotherapy, and in the maintenance setting, around for 1 year we continued pembrolizumab alone. In the adjuvant setting, post-surgery. So what happened was there was higher rates of pathological complete response, that is 65% versus 51%, and also there was an improvement in EFS. And this benefit was actually shown. This is the most important part of the study. That is, this benefit was actually shown in both the PD-L1 positive and as well as the negative patients. So we need not look at PD-L1 status in the non-metastatic setting. Next slide. Now we have discussed immunotherapy. Now the newer subset of drugs are the antibody drug conjugate. So I would actually equate this to the Trojan horse. That is, this is a monoclonal antibody and a chemotherapy substrate which has been combined into one. So what are all the newer ADCs which are approved? That is, it has a higher response rate and it has lower systemic toxicity, and it selectively kills the tumor cells so that there is bystander effect. That is, the normal cells could be effectively spared as opposed to chemotherapy. So what are the newer ADCs? The one is the trastuzumab deruxtecan, which was actually discussed previously. This TDM1, trastuzumab emtansine, is also another ADC which was approved. Later now, the trastuzumab resectecan that has come as a newer ADC with the improved linker and payload, and the phase 3 studies are ongoing. And the TROP2, anti-TROP2, which is sacituzumab govitecan, which is probably the best drug in TNBC space now, which is now shown a benefit, and also certain hormone positive metastatic breast cancer have also shown response to this trastuzumab govitecan. Next slide. So I've discussed the therapeutics part. Now coming to precision oncology and NGS in the breast space, a lot of new actionable mutations have been identified as mechanisms of resistance to breast cancer. So all these have also been able to, we have also been able to identify targets for these resistance mutations, which have been shown to improve survival. So what are they? One is the PIK3CA, that is addition of alpelisib and endocrine therapy. Now, recently, inavolisib, that is from the Innova-05 trial, has been approved in the same space. And also the ESR1, which I have discussed earlier, elastrasent. And now it is found that with even with therapy, multiple new mutants tend to arrive. So these can be identified with serial NGS testing. And also newer targets have been identified in certain basket and umbrella trials. Next slide. Now coming to MRD and ctDNA, that is MRD is measurable residual disease. This has already been practiced in hematological malignancies, especially in the AML and ALL space. Slowly, after the in the IMvigor trial in the bladder space, it has come up in a big way to identify resistant clones early. Now in breast also, we identified ctDNA. What are these circulating tumor DNA? These are actually small fragments of DNA which are actually secreted by the tumor cells. These can actually be identified very early in the progression of the disease. That is, what does ctDNA tell us? It identifies microscopic disease persisting after treatment. Also, if we identify ctDNA, we can actually identify relapse very early. And this has also become an opportunity for treatment escalation and de-escalation. So certain MRD trials have been going on, especially in the TNBC space, where we do not have any proper targets available apart from the immunotherapy and the sacituzumab. Next slide. Now, what are the clinical outcomes? So in the HER2 positive space, the onset of dual anti-HER2 blockade has improved significant OS benefit and also deeper responses. In the hormone positive space, in the metastatic setting and in the adjuvant setting, we have CDK4 inhibitors. In the metastatic setting, it has has the greatest advantage of delaying chemo and also has a longer disease control. And the TNBC, as I discussed earlier, immunotherapy when combined with chemotherapy has improved curative response and also a better EFS. And then the HER2 low space, if it is IHC negative, still 50 to 60% of tumors tend to be HER2 low. So in that space also, TDXD has been approved. Next slide. So early detection can actually improve survival, and also therapeutic landscape have evolved from just chemotherapy alone to hormonal therapy alone to CDK4/6 inhibitor to fulvestrant to elastrasent, and there are an array of drugs which I have discussed. And overall, there is all these drugs have added to improved long-term survival, and there is a shift towards biology-driven therapy. These are the key takeaways of my talk. Next slide. Yeah, thank you.
Thank you so much, sir, for the insightful talk. Our next speaker is Dr. Saeed Ismail, Senior Consultant Medical Oncologist, NGM Cancer Institute, Chennai. Sir, welcome you and over to you for the next talk.
Are my slides are visible? Hello?
Yes, sir, they are.
My slides are visible?
So kindly make them full screen. Yes, they are visible.
It's not visible to me. Can you share my slides?
Yeah, sure, sir. We will share.
Yeah, maximize my slides. Okay. Good evening to one and all. First of all, I thank the Zydus for giving me these opportunities to cover the management of ovarian cancer. Here in my topics, I am going to cover the DNA damage and role of PARP and BRCA and HRD testings guideline recommendation for treating the ovarian cancer patient and breast cancer and pancreatic cancer, and clinical evidence for treating these patients and recent evidence coming to finally conclusion. Next slide. The DNA damage and role of PARP. PARP stands for polyribose, ADP ribose polymerase enzyme, and BRCA, breast-related cancer antigen. Next slide. We know the DNA repair mechanism. These cells consistently deal with damage to their DNA. Either it may be due to the stress due to replication of DNA, or it may be due to the free radicals. It is present in the bodies, and ionizing radiation and any chemicals, chemotherapeutic agents all make the stress to the DNA, make into the repairs in the DNA. The types of repairs are base repair or DNA adducts, single strand DNA breakage or double strand DNA breakage. Once the breaks repair is happened, we have to repair with that by using this mismatch repair, and with the cells have therefore developed a indicate repair mechanism to deal with the different types of possible DNA lesions that arise, all with the goal of protecting genomic stability. Next slide. The role of PARP in base excision repair of a single strand breaks in DNA. Polyribose, ADP ribose polymerase enzyme, a protein family characterized by structural resemblance and functional similarity, consists of enzymes such as PARP1 and PARP2. These proteins contain 2 ribose units and 2 phosphate per polymer unit. Specifically, PARP1, PARP2 play a significant role in the DNA repair pathways like called base excision repair or single strand breaks. Next slide. What happens if single strand break repairs fails? Suppose if the single strand has to repair, if it is fails to repair, then the single strand DNA breakage goes to the double stranded breakage. If single strand breaks are not repaired preferentially, then the single strand breaks that cannot be repaired timely will be converted to double stranded breakage. These DNA double strand breaks in the cell cycle phase, yes, caused by replication fork must be repaired by the homologous repair. Next slide. Next slide. If double stranded break repairs, it either go for homologous recombination repair pathway, another one is the non-homologous engineering repair. HRR is a high fidelity, accurate pathway that restores the original DNA sequence by using a matched DNA strand template for the repair process, thereby making the genomic stability. Suppose if the double stranded DNA breaks not repaired by homologous repair, then it goes for non-homologous engineering classic pathway. This NHEG is an error-prone repair pathway that repairs the loose ends of the broken DNA double helix by sealing them together, which leads to genomic instability. Next slide. Here, the one is affected father, another one is unaffected mother. Having these enzymes, 2:4 ratio will be affected in the family. Both BRCA genes are tumor suppressor genes that produce proteins that are used by the cell in an enzymatic pathway that makes very precise, perfectly matched repairs of DNA molecules that have double stranded breaks. The cancer risk is caused by BRCA1, BRCA2 mutation are inherited in a dominant fashion, even though usually only one mutated allele is directly inherited. We know that BRCA1 is located in the long arm of chromosome 17 and BRCA2 gene is located in the long arm of chromosome 13. Next slide. BRCA mutations leads to cancer cells. It is a BRCA mutation known to increase the risk of multiple cancers. In that, main one is the breast cancer, second is ovarian cancer, third is prostate cancer, and BRCA1 in breast cancer is 50 to 65%, and BRCA2 is 40 to 55% in the woman. In males, it is 1.2% is seen in BRCA1 and up to 9% in the BRCA2. In pancreatic cancer, 1 to 3% are seen with BRCA1, 2 to 7 with BRCA2. In ovarian cancer, 40 to 65% is the BRCA1 mutation and 15 to 25% with BRCA2 mutation. In prostate cancer, the BRCA1 mutation is 9%, BRCA2 is 15%. Next slide. BRCA1 and 2 deficiency enables and accelerates the carcinogenesis. The loss of BRCA1 and BRCA2 genes creates genomic instability. The increased gain of function, that is proto-oncogenes, leads to oncogenesis, and loss of function events the suppression of tumor suppressor genes. It leads to multiple cancers due to mutation of this BRCA1 BRCA2 genes. Next slide. The difference between the germline mutation and somatic mutation, the somatic mutation, they occurred over a person's lifetime in a single sense. Whenever the person so the lifetime risk is associated with the somatic mutation lead to cancer. It cannot, the somatic mutation cannot be inherited. Coming to germline DNA changes, it is present in every cells of the body, including egg and sperm. It leads to cancer susceptibility in the lifetime of the patient. These germline DNA changes can be inherited. Next slide. On these somatic mutations, all tumors contain DNA errors. The somatic mutation is extracted from the tumor. Sometimes tumor proteins are studied instead of the DNA. Somatic means that the gene error has arisen in a cell during the lifespan of the person and is present only in the tumor. In the germline testing is DNA is extracted from blood or saliva to pick up inherited genetic variants. Germline means that the gene error is present in every cell of the body. It is inherited. Next slide. Coming to HRD testing. Next slide. The homologous recombination deficiency testing. HRD can be assessed through 2 different types of biomarkers. In ovarian cancer, these include mutation in BRCA1, BRCA2 gene mutation and assessment of genomic instability. HRD testing include the loss of heterozygosity and long large-scale state and telomeric allele imbalance can perform prognosis and treatment decision. For patients with advanced ovarian cancer, HRD testing may be used for predispositional insights to look for the prognostic insights and predictive insights. In predispositional insight, germline mutations of BRCA1, BRCA2 help to look for the familial risk assessment. The prognostic insight, BRCA1, BRCA2 status can provide insight to the course of the disease and to know the survival of the patients. And predictive insights, the HRD status can be used to develop a comprehensive treatment plan depending upon the positivity of the test. Next slide. These are the NCCN criteria for looking for mutation testing in the breast, ovarian, pancreatic tumors. And those patients, all the patients who presented with age less than 35 years, they will be prone to have the germline mutations. And the genes are looked with ovarian cancers are BRCA1, BRCA2, and CDH1, BALK2, P10, and STK1 genes and TP53. And the other cancers genes are also look for the ovarian cancers. In the ovarian cancers also BRCA1, BRCA2 mutation are seen. Here any family risk factors of more than 3 members are affected in the family. They have the family risk factors. For all those patients, we can look for the HRD testings. Next slide. This clinical practice guidelines for BRCA1, BRCA2 gene test is, we know the grade 1 BRCA1 test is the inherited age is less than 50 years. And the family presence of any family is with the patient suffering with the first degree relatives, and tumor genesis, any triple negative breast cancers, and metastatic hormone resistant tumors. And grade B BRCA testing criteria age is 41 to 45 years, and triple negative breast cancer patient more than 50, and a patient having the bilateral breast cancers, and the family still present breast cancer with 2 cases of breast cancers in the family. These are the risk factors to look for the clinical guidelines for the testing BRCA1, BRCA2 patients. Next slide. This synthetic lethality describes a situation in which the mutations in two genes results together. It leads to cell death, but a mutation in either gene alone does not. Cancer cells that only have one mutated gene in a specific pair of genes can depend on the normal partner gene for survival. Interfering with the function of the normal partner gene may cause cancer cells to die. Next slide. This pictogram shows that the cancer cells that only have one mutated gene in a specific pair of genes can depend on the normal partner cells of the survival. Interfering with the function of the normal partner gene may cause cancer cells to die. Next slide. Coming to the guideline recommendations. These are the guidelines for NCCN guidelines for treating the epithelial ovarian cancer patients, fallopian tube cancers, and primary peritoneal carcinoma. For patients with ovarian cancers for stage 2 4, those who went chemotherapy without bevacizumab, the patient having the germinant BRCA1 BRCA2 mutation, patient end up with complete response or partial response. The olaparib is given for maintenance therapy. And patients with previous initial chemotherapy is bevacizumab incorporated, means either the BRCA1 1 and 2 is either wild type or mutated type, germinant BRCA or somatic mutation is present. Those patients achieved complete response or partial response. HR is deficient. This combination of bevacizumab and olaparib is given. The bevacizumab is continued up to 1 year and olaparib is up to 2 years. Next slide. The NCCN guidelines for using this BRCA1 PARP inhibitors in breast cancers, the HR positive, HER2 negative patients, adjuvant endocrine therapy in the form of olaparib is given for germinant BRCA1 BRCA2 mutation with the CPS and ECG score more than 3 on any presence of residual disease. For triple negative breast cancers, presence of BRCA1, BRCA2 germline or somatic mutation, the adjuvant therapy is as a form of adjuvant therapy. Adjuvant olaparib is used for 1 year if germline BRCA1, BRCA2 mutation is present in the patients. Next slide. Next slide. According to these NCCN guidelines, breast cancer patients, the pre-operative adjuvant therapy regimes, patient presenting with HER2 negative and BRCA1, BRCA2 mutation positive, the olaparib is given as a perioperative treatment modality for those patients with germline BRCA1, BRCA2 mutation is present. Next slide. And systemic therapy regimen for recurrent unresectable for local or regional for stage 4 metastatic breast cancers. For as a first line, the germline is germline BRCA1 BRCA2 mutation is present. PARP inhibitors like olaparib and talazoparib are also indicated in these patients. Next slide. Systemic therapy regimens for recurrent unresectable local regions for stage 4 patient for triple negative breast cancers with the PDL1 CPS scores less than 10% and germline BRCA mutation 1 and 2 is positive. The indication is PARP inhibitors like olaparib and talazoparib is indicated as a category 1 preferred, and the platinum-based chemotherapy is used for these patients. And second line as a germline BRCA1 BRCA2 mutation is positive in the patient as a second line. PARP inhibitors also prefer to use for these patients. Next slide. Coming to the guidelines according to for the prostate cancer, the systemic therapy for metastatic castration-resistant prostate cancer in the adenocarcinoma, olaparib and abiraterone is used for somatic mutation of BRCA gene mutation, and for progression disease for after progression on prior docetaxel, no prior novel hormone therapy is given. Olaparib and abiraterone is indicated for BRCA mutation. progression on prior novel hormonal therapy and no prior docetaxel, olaparib for BRCA mutation is indicated, and olaparib for HRR mutation other than BRCA is also preferred to give BAP inhibitors. And progression on prior docetaxel and Knoxal hormone therapy, olaparib is preferred for homologous recombination repair mutation as a category 1 indication. Next slide. According to ASCO guidelines, the PARP inhibitors in the management of ovarian cancer, rabbit recommendation. Here, the PARP inhibitors, olaparib, is indicated in the first remission as a maintenance therapy for both germline and somatic BRCA mutation, and the second line also, second remission and greater remission. The for olaparib is used in both germline and somatic BRCA mutation. Olaparib combined with bevacizumab is used for germline somatic BRCA in the HRD positive, and niraparib is used for HRD wild type germline and somatic BRCA mutations. Rucaparib is germline and somatic BRCA mutation with HRD wild type. Next slide. Coming to clinical evidence to treat with olaparib in the ovarian cancer patients. Next slide. According to Solo trial, Solo 2 trial, olaparib versus placebo maintenance in patient with platinum-sensitive relapsed high-grade CA ovary with BRCA1, BRCA2 mutation who had received more than or equal to 2 prior lines of chemotherapy. Next slide. This Solo 2 trial shows that the median progression-free survival significantly improved median progression-free survival by 13.6 months versus placebo, with 70% lower risk of disease in the reduction and death, 4 times longer with when compared with placebo in median progression-free survival. Next slide. The Solo 2 final overall survival analysis, the median overall survival improved by 12.9 months with olaparib and as a maintenance therapy versus placebo, despite 38% of the placebo patients receiving subsequent PARP inhibitor therapy in placebo arm. Next slide. And the time to subsequent therapy and duration of treatment exposure, olaparib significantly extended the time to first subsequent therapy. In olaparib, this olaparib, which is 28% are seen. In placebo, it is only 30% in the time to subsequent therapy. Next slide. The overall final safety analysis, the potential MDS AML association with prior platinum regimen, olaparib and other risk factors being explored. This risk is with olaparib is 2 patients, and in the placebo arm is only 4. The pneumonitis changes with more with the olaparib arm when compared with the placebo arm. Next slide. This is a treatment emergent adverse events with incidence of more than 15%. Most common side effects with olaparib are nausea and fatigability is the most common side effect. Anemia is also seen in the patient, vomiting, diarrhea, and headache, constipation are these are all the some of the side effects as observed in the olaparib arm. Next slide. Thank you.
Thank you so much, sir, for the wonderful talk. I now invite our program convener again, Dr. Arun Ramanan, Clinical Lead and Senior Consultant, Medical Oncology, Clinical Health City, Chennai. Sir, over to you for the closing remarks.
Yeah, good evening. It's a very nice illustration from various our eminent speakers today. Right from I had a good hearing from Dr. Priyadarshini when she was nicely illustrating on the various management roles in the ovarian cancer. And if you see, each one of us have very well justified their role here. And I would like to thank all the eminent speakers today. She also covered, Dr. Priyadarshini also covered the role of newer therapies into the advanced ovarian cancer. And when it comes relapsed, it's always a difficult situation. Platinum sensitivity and platinum refractoriness are all key predictive for the treatment and further outcome, as well as new biological markers and molecular markers, and even mutational status like HRD are also playing a vital role in deciding various therapies. That was clearly given by Dr. Priyadarshini with her slides. And also, Dr. Vedant Rai clearly explained on the management of breast cancer as of now in this 2026, with all the advancement from latest guidelines and as well as various latest seminars around across the world. I'd like to thank Dr. Vedant for giving the detailed illustration on managing breast cancer. He also explained on various newer clinical trials with all the ADCs and newer therapies. It's quite very much interesting to hear his talk today. I really appreciate Dr. Vedant Rai for his nice speech today. And when we move on to that management of breast cancer with all the advances by again Dr. Sriram, it's a kind of actually overlapping topic, but anyway, Dr. Sriram did all the justification to the topic given to him. He very well clearly explained the various treatment paradigms and treatment options available for the managing breast cancer. Coming to Dr. Syed Ismail, my senior, he has clearly given the outline for the ovarian cancer management with all the PARP inhibitors and their role there in managing the cancer, advanced ovarian cancer. And recently also, interestingly, there are a lot of new drugs coming into the armamentarium, joining there. Like recently, we have seen a bispecific anti-HER2 inhibitor therapy in the form of zanidatamab. That's Zanida. Sorry, I'm not very sure. That is a zanitumumab. Correct. If I'm not wrong. Anyway, excuse me for the mistake with that pronunciation. But that drug is a bispecific HER2 inhibitor, which binds both in the ECD2 and extracellular domain 4. That's a quite interesting drug now. It is tested with the tislelizumab for managing the HER2 positive advanced breast cancer. So these kinds of new drugs are bringing light to this therapy. We are more and more with the more advanced treatment armamentarium, we are able to extend the survival. I would like to even ask Dr. Sriram if he is there about all the this newer bispecific antibody if he is scared of. Dr. Sriram?
Yes, sir.
Yeah, have you heard that? Interestingly, I learned that about yesterday.
Yes, sir. Zanidatamab has come in newly, sir. Initially,
correct.
Yes, sir. Initially, it was actually there is data for it in the biliary tract cancer, which was
Okay.
and later actually it has been extended even to stomach and GI. Breast actually is data I have not yet seen, sir.
Oh, right,
Whether
right.
it's out,
Okay.
I'm not aware, sir.
Oh, right. But anyway, it's a good drug coming into the treatment field. Like similarly, Dr. Priyadarshini, I have a question for you. Dr. Priyadarshini, are you there? If not, then, sir, Dr. Ismail, are you there, sir? Dr. Vedant?
Yes,
Arun,
sir.
I'm here.
Yes, sir. Sir, you gave a very good talk on this advanced ovarian cancer management. I have an interesting question. Sir, what is your approach when a patient is progressing on a PARP inhibitor therapy? In a advanced ovarian cancer, if a patient is progressing after a PARP inhibitor therapy, like after some response for 1 or 2 years, if the patient is progressing, what is your approach, sir? Can you go and re-challenge again with another PARP inhibitor, or what you have to necessarily go for chemotherapy or any role of immunotherapy? What is your idea, sir?
No, for suppose if recurrence is there, means I will go with this HRR inhibitors. Again, we have to testing. Suppose here mainly this chemotherapy is a treatment of choice. After progressing after 2 years, means it is platinum sensitive tumor only. So really challenge with the platinum with bevacizumab.
No, sir. If
And
after BRCA inhibitor, if BRCA inhibitor maintenance, after the BRCA inhibitor maintenance, if like we are reading about the solo one, what if a patient progresses after 2 to 3 years after the PARP inhibitor? What is your approach?
My first preference is chemotherapy only.
Chemotherapy only.
Yeah.
Okay, sir. Sriram, any idea from your side?
Sir, practically doable is chemo, but as
Yes.
such, we have survival data for this folate receptor alpha inhibitors.
Oh, right. Okay. Folate receptor antagonist. Right, that's a good newer therapy coming into that.
Mirvetuximab soravtansine.
Yeah, that's correct. Mirvetuximab is there. But usually, like Ismail sir mentioned, we will be usually treating with some chemotherapy as of now because of so many factors coming into the, like kind of financial ability. Like otherwise, we will go with the chemotherapy and may add bevacizumab to it. Even if bevacizumab is also exposed in first line, then we will be left with mostly chemotherapy. The newer roles, like as you mentioned, many and many drugs coming. There are interesting data like you can even re-challenge with the PARP inhibitor if there is at least a 6 months gap from the last exposure of PARP inhibitor. There is a reversal of BRCA is there. There is also interesting paper we can see. If still the patient is HRD positive and BRCA is mutated, we can use some other BRCA PARP inhibitor, like sometime. Yeah, if olaparib is failed, we can interchangeably use niraparib or rucaparib. But I am not sure how much benefit the patient is going to get. But there are interesting data coming across with a challenge of PARP inhibitor. It's quite interesting. Right. Anyway, so Sriram, for which patient you will consider, though it's not your topic, I'm just for the matter of concern I'm asking, for which patient you are considering neoadjuvant bevacizumab? I will first ask you and then I will go to the other panel member. Just for understanding, I'm asking. In CA ovary.
In CA ovary. Sir, usually neoadjuvant adding bevacizumab, maybe, sir, if interval cytoreduction is planned, then it will be difficult. So, preferably go with chemo first, and the patient has ascites upfront.
Right.
That kind of setting, maybe bevacizumab.
Yeah, large volume ascites, large peritoneal deposits. Sometimes with the pleural effusion positivity, we may tend to use bevacizumab because we need a good response to convert that patient into surgery. Malignant cytology alone positive, not parenchymal lung metastasis.
Again, sir, we have to stop it at least 1.5 months before.
6 weeks before the planned
surgery.
Yes, and that too, if sometime CT scan is showing very good tumor deposit sitting on the bowel, then that patient may not be a suitable candidate for exposing to the bevacizumab because there is every chance, perforation can happen with the bevacizumab. Sir, Ismail, sir, do you agree or do you have any other different idea?
Yeah, I will agree. Mine is presence of gross ascites. One of the indication, presence of pleural effusion and presence of the nodes. It is parietic nodes above the hilum, renal hilum is there. We have to consider this bevacizumab.
Yes, very good, sir. Like Sriram said, so many newer therapies are also coming into the field. Recently, many newer drugs are invented into this armamentarium and added to that. So it's a quite good future. Yeah, folate receptor antagonist, as Ismail sir is also explaining about. It's a quite interesting thing. So hoping for the good outcome in near future. It's a bright future to come across. The long-term survivors are definitely having a good.
Lot of novel agents are coming into place from trials to bedside. Only thing remembering
any role of immunotherapy, sir? Any role of immunotherapy in ovarian cancer?
So far, I have not, in my practice, I have not used this immunotherapy drug, and there is no studies also for this using this immunotherapy in CA ovary patients.
Okay, okay. Sriram, your idea, Sriram?
Yes, sir. No, in CA ovary space, at least immunotherapy, no, sir.
Dr. Vedant, is he available? Dr.
Yes, sir.
Priyadashini?
Yes, sir.
Yeah, please, Vedant, you must be hearing our discussions. Any idea
Yes.
or any your input over to that?
So pembrolizumab till date we have used only on 3 patients. Over the
Okay.
last 1 year, 3 patients we have used. Mostly
For
were like
ovarian
see,
cancer you are talking.
ovary,
Okay.
yeah. Post
Okay.
topotecan.
Hmm.
So as
So that
such,
means you are telling for a recurrent platinum
platinum resistant.
resistant ovarian cancer.
Yes,
Okay.
yes, sir.
Uh,
So platinum
what
resistant.
biomarker you used to consider for exposing the patient to immunotherapy, Vedant? Any idea?
We used PDL1 22C3. So
Okay.
score
Or
more than 1.
MSI or what usually you will use as a tool for predicting the response? MSI or PDL1 testing, CPS?
So in ovarian, most over third line, we were using PDL1 alone here.
Okay, okay, okay. Over
So
third line means after chemo and some PARP inhibitor therapy, you mean to
yes,
say?
sir. Yes, yes,
Right,
yes.
good. That's my area of I would like to project to you. Yeah, right, correct. Proceed, Vedant. Your idea on that, yes, please.
So
So how was the
we
response to Pembro?
yeah, so roughly around 6 months of, I think one patient was on 4 to 6 months, and it was not that great response, to be honest.
Right.
So, except one patient, both the patients didn't respond that well.
Yeah. So far, not like any other tumor. Yeah, please.
Whether there is any papers or trials to have any guidelines to use this
Sir, it's
pembro
in the
in
second, third line, right, sir? It's in the platinum resistant second and third line. In context of clinical trial, you can try some drugs there. You don't require literature to support your therapy, but at least if some response is there, we cannot just like that waste a drug because it's a costly drug. Some literature
actually
may be required.
We have multiple drugs like topotecan is there. We have multiple drugs. This oral metronomic therapy can be also used with like capsaicin with etoposide. These are all drugs
But
also we
most of
can
the time,
try.
the performance status will be very, very low.
Poor.
Patients may not be tolerable for all the aggressive chemotherapies. So immunotherapy could be a good option because the side effects are very less.
Yes. But that's what I'm saying, that it's mostly more than third line, more than third, fourth
Yes.
line. We have no
Yes.
other options. Patient's PS is actually 2 or 3. So
Yes.
still the family looks up to us or something. So, and the PDL1, though has no such significant role, if more than one, we actually we did. But after the results of 2, 3 patients, we are not seriously considering. So it was last 1 year back we have done that.
Yeah, in endometrium also you have seen that pembrolizumab with lenvatinib is giving some amount of benefit, like a metronomic fashion. Yeah, why not? We can try it in a platinum resistant to ovarian cancer when all the frontline options are exhausted. Your point is well taken, Vedant. So coming to your domain, like today's presentation, what do you think on the role of immunotherapy in CA breast? On what drug you are currently comfortable with in CA breast? Because we have plenty of immunotherapy options for managing CA breast as well. Your idea on that, Vedant, it will be a valid input.
Yes, sir. In triple negative breast cancer is non-metastatic, as Dr. Shriram has presented, keynote 522. That is definitely, it's a widely practiced protocol. And in the metastatic setting, in the second line, of course, irrespective of the CPS score, we are going for pembrolizumab with chemotherapy protocol. And yes, beyond third line, also we have only one patient on sacituzumab with pembrolizumab, that is ASCENT 4. Only one patient we do have. Otherwise, pembrolizumab in non-metastatic TNBC, we are widely practicing. And in the metastatic setting in line 2, yes, we are definitely practicing, sir.
How about the newer immunotherapies coming into that, like a kind of toripalimab, tislelizumab?
Yes.
Their data is also quite impressive,
Yes,
and
yes.
also they are at the same time affordable.
Yes, sir.
And the other thing,
Any,
for in metastatic breast cancer, triple negative, the CPS score should be more than 10% for pembro. For toripalimab, it is more than 1% is enough.
1%.
Yes, sir.
Yeah.
Yes, sir.
that's a good point. Now we are having extended options to try for them.
Yes.
And yeah, if that is going to be financially as well as affordable, why not we can have a good try there. And
Previously in triple negative, this atezolizumab also used. Nowadays it is
But
removed by
now,
the
sir, so OS benefit was not there. So we are pembro was
removed that one from FDA.
NCCN has
yeah, both
removed.
atezolizumab and nivolumab is withdrawn from the management of triple negative. Yeah, still the pembrolizumab and tislelizumab, toripalimab, these are all the drugs currently available. And along with the newer ADCs, what Vedant said, like saxatumab, govitecan, and yeah, there is another one, no? Depotumab, something.
Datapotamab deruxtecan.
Yes.
Yeah, that's also there. It's all new drug. And sometimes if there is a 1+ or 2+ positivity seen with the HER2, maybe call it a triple
HER2.
negative, but if at least there is some expression in HER2, then we can still use TDXT there. It can be vital there. It's a good thing. Any other input from anybody, sir? For any HIPEC regarding what is the role of HIPEC, sir? How you see HIPEC now? Because surgeons are coming across with a lot of interesting trials in the ovary management with HIPEC, bringing HIPEC into the frontline interval debulking place. How about how you see that, sir? Ismail, sir, your valid input.
Depending upon the institute where we are practicing, in our institute, these HIPEC are routinely using by our surgeons as front also. And some of them, if a HIPEC is not possible for them, they will put on this intraperitoneal chemotherapy also.
Oh, right.
IP chemotherapy. Yeah, we are practicing all this HIPEC and IP chemotherapy in our.
Sir, I would just like to add one point, sir. So after going through the recent ESMO data, especially on this intraperitoneal chemotherapy, I feel slowly the concept is delay the progression as late as possible. Make the tumor as resistant, as sensitive to platinum. Make the relapse as a sensitive relapse. So maybe in that setting we can actually practice intraperitoneal chemo. But then HIPEC assets are did not show a benefit in the upfront setting. Interval cytoreduction, yes. In that setting, yes. But upfront HIPEC did not show any benefit.
But that OVPAC trial is there, right? OVPAC says there is a good improved outcome seen with interval, the HIPEC when added to the interval cytoreduction there.
So
there is
interval,
one trial
yes, sir.
which
Interval setting, yes, sir.
Yeah,
but
upfront
not as a
is
primary.
not. Primary,
yes.
yeah, primary. That I accept. Very good, very good, very good point. Vedant, from your institution, any idea on that?
Yes, sir. In our setting, it's mainly the interval CRS and the secondary CRS. So both have the data, as Dr. Shriram and Dr. Ismail has said. So we are following the interval and the secondary CRS, HIPEC. Yes.
Hello.
Hello.
Sorry, am I audible? Yeah.
Yes, sir.
Yeah. What is the chemo protocol you are using for HIPEC? You use cisplatin or what drug there?
Yes,
what
sir.
dose?
We're using cisplatin at 100 mg per meter square with a hydration of at 2.5 liter per meter square. So that's what we're using, right? Yes, sir.
You are comfortable with that 100 mg per meter square, right? Or any toxicity?
Actually, based on the patient's PS, yeah, we clinically examine the PS and the patient's RFTs, the creat clearance and everything. So we try to induce 100 mg per meter square, but we do modify at times. But that's our goal, sir.
Sir, Ismail sir, your institutional protocol, sir?
Yeah, for our institution protocol also same only. Cisplatin 100 mg per meter square with hydration of 2.5 liters per meter square.
Tolerance is there, right? Okay.
Yeah, tolerance is there. But depending upon the general condition of the patient, we just modify. From 80 to 100 mg per meter square, we are giving.
Good, sir. Good. Right. Thank you, sir. Thank you very much. I think we have covered wonderfully all the topics. Right from very much newer advancements happening in the breast cancer and as well as ovarian cancer. Thanks to all the speakers. Thanks for their participation. Thank you very much for the organizing team to conduct this conference with a wonderful seamless connectivity. Thanks to the sponsors for this today's meet, right from all the companies like Glenmark and the Intas team. Thank you very much. Thank you for everybody. Thank you.
Thank you.
Thank you,
Thank
sir.
you, sir.
Thank you. Thank you,
Thanks a
Vedant.
lot,
Thank
sir.
you, Sriram.
Thank you,
Thank you,
sir.
Priyadarshini. Thank you.
Thank you.
Thank you so much.
Thank you, all the doctors. Thank you, support team. Thank you all, and good night to all.
Tech team, please close the session. Thank you so much.